Hello, my name is Ron Daniels. I'm a full-time NHS consultant working in intensive care with an anaesthetic background. But in my spare time I'm Chief Executive of the UK Sepsis Trust and the Global Sepsis Alliance. 10 years ago, I looked after a young man called Jem. Jem was 37. He was a fit, strong man. He was in bed 4 in my intensive care unit, and when I first met him, it was very clear he was critically ill. During that day, he started to deteriorate further, and it became clear that despite everything we were doing for him, he was not going to make it. So I remember as clear as it were yesterday, following his wife Karen down our hospital corridor to a relative's room, where I knew I was going to take this young woman into the room and tell her that her fit, strong husband, her rock, wasn't going to come home, and that she was going to have to go home and tell their children, Tom and Emily, that Daddy wasn't coming home, and all from a condition they'd never heard of. That was the time I knew that we had to fix this. So we had a problem. We had complex clinical guidelines. We had a complex set of recognition tools for sepsis, and these were known of by the critical care community. They were known of by the emergency medicine community, but weren't understood and weren't known throughout our healthcare system. The key to our success, and the key to what we're trying to do now, is simplicity. We doctors are not very good at simple. We doctors like complex. But in order to achieve reliable delivery of care, we have to simplify. So one of the first things we did was create the Sepsis 6, a simple bundle of care that should be delivered to all patients with sepsis, and that we've subsequently modified to become the paediatric Sepsis 6. That wasn't enough. The Sepsis 6 disseminated. It's now in place in countries as far afield as the United States and Australia, but on its own, it's not going to achieve a lot, because it's only of use if it's implemented early. And to implement early, we have to recognise. And that's where these clinical toolkits come in. We've taken the international consensus definitions for sepsis and we've simplified, and we've made them relevant to the United Kingdom. We've linked them to the National Early Warning Score, so that when we, as a junior doctor or nurse, are on the ward, taking observations, looking at observations, looking at news charts, we can use that as a trigger to implement the toolkit. So what we'd like everybody watching this to do is to have a look at our website, to look at the clinical toolkits, to understand the one that most closely affects them in clinical practice. And when they've understood it, to start to use the terminology within it. We use the term red flag sepsis, so that when somebody has a physiological deterioration that we can identify right at the outset, we are going to assume this patient is severely ill with sepsis, and we're going to deliver the Sepsis 6. So let's start talking red flag sepsis. Let's get it into our psyche. Let's use it as a communication tool to describe the seriousness of the condition. Have a look at our website. Look at the clinical toolkit. The screening and action tool is the one of most direct relevance, because that's the pathway you're going to use at the bedside. Talk sepsis, talk red flag sepsis. Tell your patients and their relatives if they've had sepsis, this has been sepsis. When you've understood and absorbed the information and you're ready to start using the clinical toolkit, then please let us know about it through the website. 37,000 people are dying every year in the United Kingdom from sepsis. If we just get the basics right, even 80% of the time, we can save an extra 12,500 lives in the United Kingdom. And it's more than that. If we get early treatment right, long-term complications like post-traumatic stress disorder, chronic fatigue syndromes that affect a large proportion of sepsis survivors are reduced. We can improve quality of life, we can save lives, we reduce length of stay, and therefore we enable money to be appropriated elsewhere where it's badly needed. Thank you.